Okay, so in this video, we will be covering the ECG changes in case of right ventricular hypertrophy. So before that, I would just like to spend a moment and revise the ECG changes that we will be seeing in case of left ventricular hypertrophy. So there were a few concepts, if you remember, that I discussed in the previous video in case of left ventricular hypertrophy, which if you want, you can pause this video and have a look at those concepts before studying right ventricular hypertrophy, because the concepts that I'm going to talk about in this video are not in that detail as they are in the previous videos. So definitely I would recommend pausing the video and having a look at the previous videos. Now, if you remember, we did that increase in the amplitude or the voltage of the QRS complex is one of the most important criteria for diagnosing a patient as having LVH based on the ECG. Okay, and why are we having increased voltage of the QRS complex? Because we know now the muscle mass in the left ventricle has increased. Okay, so the voltage detected by the recording electrodes will be more than what it used to detect before there was ventricular hypertrophy. The second is increased duration of the QRS complex. So definitely the time that it's going to take for the electrical current to reach the electrode will be more, because now the impulse has to travel greater distance. Okay, and it's going to take more time for the ventricles to be depolarized. Therefore, the duration of the QRS complex will be more. Then whenever we have left ventricular hypertrophy, there are high chances that you'll be having coexisting left atrial abnormality, and therefore we will also be able to see left atrial abnormality ECG changes. For example, notched, bifid or M-shaped P waves which have increased in duration but the amplitude is still the same. Then you can also see left axis deviation, in which the axis of the heart will be shifting towards or more than minus 30 degrees, because now the left ventricle has enlarged and the axis of the heart has been shifted more towards the left. So now coming on to the last concept of ST and T wave abnormalities in V5 and V6. I think I have spent a good amount of time discussing the basis of the ST depression and T wave inversion in left ventricular hypertrophy. We will be having a similar kind of a thing in case of right ventricular hypertrophy. So this was kind of like a summary of the ECG changes that you see in case of left ventricular hypertrophy. Now I'm going to compare these with the changes that we'll be seeing in case of right ventricular hypertrophy. So coming on to the first one, that is the increased amplitude and voltage of the QRS complex. Now we do consider the increased voltage and amplitude of QRS complex in case of right ventricular hypertrophy, but even more important than this is the nature of the deflection. Okay, that means, for example, in the leads V1, where we are supposed to have a negative deflection, we'll be having a positive deflection in case of right ventricular hypertrophy. Here the amplitude is not that important as is the direction of the deflection. Okay, so the direction of the deflection will be more important in case of right ventricular hypertrophy. This is something that will be more clear once I show you the criteria that we used for labeling the patient as having right ventricular hypertrophy and the ECG abnormalities that we see in case of right ventricular hypertrophy. The only thing that you need to remember for the time being is that the deflection of the QRS waves are very important in case of right ventricular hypertrophy, more important than the voltage. The second is the duration of the QRS complex. So in case of right ventricular hypertrophy, we do not have increased duration of the QRS complex. So what's the reason behind that? The reason is that the left ventricle is still thicker than the right ventricle in case of right ventricular hypertrophy in most of the cases. By that I mean to say that even though if you say that a patient is having right ventricular hypertrophy, The thickness of the right ventricle has not reached that of left ventricle. Therefore, it is still thinner than the left ventricle most of the times. Even though it's not always the case, sometimes you can really have thickened a right ventricle, but that's not in most of the cases. So therefore, the duration of the QRS complex does not change most of the times in case of right ventricular hypertrophy. Next, coming on to the left atrial abnormality. So just like we have left atrial abnormality in case of left ventricular hypertrophy, we will be having right atrial abnormality in case of right ventricular hypertrophy, which is generally seen in the form of P wave changes in the ECG, in which, if you remember, we've talked about that how we have peaked P waves in case of right atrial enlargement. So those are the changes that we might see along with right ventricular hypertrophy changes. Okay. Then just like in left ventricular hypertrophy, we have left axis deviation. In case of right ventricular hypertrophy, we will be having right axis deviation, in which the axis is gonna be around 80 to 120 degrees. The right side of the heart will enlarge in size and will contribute more to the generation of the vectors. And coming on to the last thing, that is ST and T wave abnormalities. We do have ST and T wave abnormalities in right ventricular hypertrophy, but the leads in which we are going to see this change are V1 and V2. So if you try to imagine a picture in which you have ECG leads put on over the chest, you'll see that the leads V1 and V2 are more close towards the right side of the heart, and the leads V5 and V6 are closer towards the left side of the heart. Therefore, leads V1 and V2 best represents the right ventricle, and the leads V5 and V6 best represents the left ventricle. So that is in summary what we are gonna study. So starting off with some of the common causes of right ventricular hypertrophy, just like in left ventricular hypertrophy, we had pressure overload and volume overload. We will be having pressure overload and volume overload in case of right ventricular hypertrophy as well. Okay, so if you see in pressure overload, some of the common causes are pulmonic stenosis, then primary pulmonary hypertension. In case of volume overload, there's going to be increase in the volume in the right ventricle. Therefore, this is a condition that you can see in case of atrial septal defect or tricuspid regurgitation or pulmonary regurgitation. Now, in case of pressure overload, there will be increased thickness of the right ventricle. But in case of volume overload, there will be increase in the cavity size of the right ventricle. So the concept is same just like we did in the right ventricular hypertrophy. So now it's just not only the pressure overload and the volume overload which will be causing the right ventricular hypertrophy, but there are certain other causes that I think are worth mentioning at this point. So a case in which you can have an anatomical distortion between the heart and the chest wall, for example emphysema, can also present with certain ECG changes. And then when you talk about the left heart failure, this can also contribute to the right heart failure. Therefore, if you are having left ventricular hypertrophy and then you develop heart failure, you can have those back pressure changes onto the right side of the heart, leading to right ventricular hypertrophy. So the changes in the ECG can be abrupt or insidious. Abrupt is something that you can see in case of pulmonary embolism, or it could be insidious. So the ECG presentations in different clinical settings are not necessarily similar. You can have different criteria being held true in different scenarios, okay, because of the different okay, just like I discussed few concepts before going into the true criteria of the LVH in the previous video, I would again like to touch on certain concepts so that it's easier for you to remember the criteria. Okay, starting off with the first one, that is in case of right ventricular hypertrophy, the prolongation of the QRS does not usually occur. Okay, so what's the reason behind that? So because of the thinner wall of the right ventricle and the smaller mass, the right ventricle generally does not contribute significantly to the generation of the Curious complex. Okay, if you see the net vector of the Curious complex, that is directed towards the left, and it's mainly contributed by the left side of the heart, including the left ventricle and the apex. Okay, so when the ventricles are synchronously activated, the forces generated from the right ventricle are masked by those generated from the left ventricle. Okay, but in case when there is right ventricular hypertrophy, the right ventricular wall becomes thickened. Okay, you can see thickening of the right ventricular wall, and the right ventricular mass is increased, resulting in a larger contribution of the right ventricle in generating the Curious complex. Definitely the Curious complex will now start to have more component of the right ventricle as well. But the point is that in adults, the thickness of the right ventricle does not exceed that of the left ventricle, even when the right ventricular hypertrophy is present. Thus, the ECG changes of the right ventricular hypertrophy continue to be masked by the forces generated by the thick left ventricle. Okay, so the right ventricle is still not able to reach the thickness of the left ventricle. Therefore, the Curious complex is still contributed by the left ventricle itself. Okay, but in certain types of congenital heart diseases, however, the right ventricle wall is much thicker than the left ventricular wall. Okay, so it's gonna be really thicker. Okay, and in these cases, the ECG findings of RVH become more obvious. Okay, so at that point, you might have prolongation of the Curious complex. So coming on to the next one, that is right axis deviation. So we know that in left ventricular hypertrophy, we have left axis deviation, in which the axis of the heart can be towards this side. Okay, that can be even more negative than minus 30 degrees. But in case of right ventricular hypertrophy, the axis of the heart will shift towards the right side, such that now it will be more than plus 90 degrees. Okay, so we know that the normal axis of the heart has to lie between minus 30 degrees and plus 90 degrees. Okay, in case of right ventricular hypertrophy, there is going to be shift in the axis of the heart towards right side. Right axis deviation is one of the most reliable signs in the diagnosis of RVH. So because the right ventricle is interior and to the right of the left ventricle, increase in the right ventricular mass will shift the Curious complex to the right and interiorly. Okay, thus the axis of the Curious complex is shifted towards around 80 degrees to plus 120 degrees. Okay, this is where the axis in case of right ventricular hypertrophy will be lying. Okay, and RVH is the most common cause of right axis deviation. Therefore, in an ECG, if you're looking at the limb leads and you make out a conclusion that it is indicating that there is presence of right axis deviation, that probably means that the patient might also be having RVH, because RVH is the most common cause of right axis deviation. Okay, coming on to the S1, S2 and S3 pattern. So what does this mean? So this pattern simply means that there is an S wave in leads 1, 2 and 3. So if you look at the ECG pictures below, you'll see that the red one is actually the normal ECG, and in this ECG I'm going to show you the S1, S2 and S3 pattern. So when you look at the leads 1, 2 and 3 in the normal ECG, you will see that the major part of the QRS complex is being formed by the R waves, which are positive in deflection. But when you see the ECG below, you'll see that the S wave is the one that is forming the major portion of the QRS complex. Okay, so you can see S waves in leads 1, 2 and 3. So now the question is, why has this happened? What is the cause of these S waves in the leads 1, 2 and 3? Okay, so if you look at this diagram which I've drawn in pink, it is representing the limb leads in frontal plane. Now we know that the major part of the vector of the ventricles is directed this way. Now according to this, you will see that it will be showing a positive deflection in the leads 1, 2 and positive to nearly isoelectric in leads 3, because now the positive side of the vector of depolarization will be facing the recording electrodes, which are leads 1, 2 and 3 in this case. So we know from the concept that we have discussed previously that when the positive side of the vector faces a recording electrode, the deflection will be positive. And this is what is happening in case of normal ECG. You are having positive deflection in leads 1, 2 and almost isoelectric to positive in lead 3. But in case of excessive right ventricular hypertrophy, you will see that the vector will be directed towards this side. Okay, now because of this, everything will be reversed in the leads 1, 2 and 3. Therefore, you will be seeing major part of the QRS in the form of S waves in leads 1, 2 and 3. So this is the reason why we see this pattern, that's S1, S2, S3. So coming on to the next concept of the abnormalities of the P wave in case of right ventricular hypertrophy. So this is something that's going to be a revision of the P wave changes that happen in case of right atrial abnormality. This is something that we've already done and I've made a separate video for this as well. So if you want to pause this video and have a look into greater detail, you can definitely do that at this point. If not, then I'll be giving a quick summary right now. So that being said, if you have right ventricular hypertrophy, you can have right atrial abnormality. And how do we know that and how do we see that in case of ECG? We will be looking the limb leads, especially the leads 2, 3 and AVF, which are really good leads to look for the P wave changes. Okay, so in case of right atrial enlargement, we will have peaking of the P waves. Okay, so you will not have increased duration, but you will have increase in the amplitude. Okay, why don't we have increased duration? Because the time that the impulse takes to travel that extra part of the right atrial muscles is still gonna coincide with the activation of the left atrium. Therefore, there is no net increase in the duration of the P wave, but definitely we will be having peaking of the P waves. So just a comparison and a revision, in case of left ventricular hypertrophy, we can see left atrial enlargement changes, which is something that will be seeing in the form of changes in the morphology of the P waves, again in the leads 2, 3, AVF mainly because they represent the P wave really well. So the changes that you're going to notice are bifid or M-shaped P waves, in which the initial portion of the P wave represents the activation of the right atrium and the later portion is representing the activation of the left atrium. and in this case is completely opposite to that of the right atrial enlargement, in a way that you will have increased duration but no change in the amplitude. Okay, but in case of right atrial enlargement, we were having increase in the amplitude and no change in the duration. So changes in the P waves are representing right atrial enlargement can be used as one of the criteria for diagnosing a patient as having RVH based on the ECG. So now the another change that you can see in an ECG with RVH is going to be tall R waves in leads V1 and V2. Now this is a very important concept, so just try to understand it and listen to me carefully. So the above picture is a normal ECG, okay, and if you see the leads V1 and V2 have been highlighted in blue, and then leads V3, V4 in yellow, and V5 and V6 in red. So why have I done this? Because I want to make one thing really easy for you guys, and that is that in the leads V1 and V2, the major part of the QRS complex has a negative deflection. Okay, you can see that this is a negative deflection. Then when you talk about V3 and V4, it's mainly isoelectric. That means that the QRS complex is having an equal positive and a negative deflection. And if you remember from my previous videos, you will also know that the leads V3 and V4 constitute transition zones because they have isoelectric QRS complexes. Then when you come on to V5 and V6, you will see that the net deflection is positive. So this is a normal pattern, and I highly recommend that you remember this pattern. So before I discuss about the changes that happen in case of right ventricular hypertrophy, that is the tall R waves in the V1, V2, I just want to discuss that why is it that we are having negative deflections in case of V1, V2, isoelectric in case of V3, V4, and positive deflections in case of V5 and V6. So the reason behind that is, if you look at the figure below this one, you will see that the major part of the ventricular depolarization vector is directed towards left side. Okay, it's directed towards the left side. So when you have a recording electrode placed here, it will be recording a positive deflection because the positive head of the depolarization vector is facing the recording electrode. Therefore you will record a positive deflection, and this is what happens in the leads V5 and V6. Therefore they have a net positive deflection. When you talk about the leads V3 and V4, so the leads V3 and V4 will be lying somewhat over here. So the leads V3 and V4 are lying almost perpendicularly to the leads V5 and V6, and we know that when we try to record current in a perpendicular lead, it will show an isoelectric deflection. Okay, now coming on to the leads V1 and V2, if you'll see, this is the direction of the net vector and this is the lead 1 position, and it's almost opposite. Therefore you will be having net negative deflection because now the negative side of the vector is facing the recording electrode. Therefore you will have a negative deflection. So this is the reason why we have negative deflection in the leads V1 and V2, and isoelectric in case of V3, V4, and positive net deflection in case of V5 and V6. So you see, through this we get to know that it's so important to know the positioning of the precordial leads, okay, also the limb leads. So positioning of the leads and the direction of the vector is very important if you want to understand how the different waves of the ECG are formed. Now coming on to what happens in case of right ventricular hypertrophy. So in case of right ventricular hypertrophy, you'll be seeing tall R waves in the leads V1 and V2. So if you look at this ECG, which is representing the right ventricular hypertrophy, and look in the leads V1 and V2, you will see that you're having tall R waves. But this is something that we do not generally see in a normal ECG. We see negative deflections, okay? We see S waves. We do not see R waves in V1, V2. So why is this happening? Again, this is happening because now the vector which was facing more towards the left has shifted towards the right. Okay, now it has shifted towards the right, and you will see that the positive head of the vector is facing the recording electrode, therefore you will have net positive deflection. So this is the reason why we start to see positive deflections in the leads V1 and V2 in the form of tall R waves. Okay, so this is a very important RVH change in an ECG. So in other words, you'll see that the RS ratio will be more than 1 in leads V1 and V2. So if you carefully look, these are the R waves and these are going to be the S waves. So you'll see that the R waves are taller than the S waves, therefore the ratio is more than 1. Okay, so the RS ratio becomes more than 1 in case of RVH in the leads V1 and V2. But when you look at the normal ECG, you will see that the S waves are taller than the R waves. Okay, S waves are taller than the R waves, but in case of RVH, the R waves are taller than the S waves. Okay, and all of this happened because of the shift of the vector towards the right side. Okay, so coming on to the next concept, which is the presence of the RS complex from V1 to V6 along with right axis deviation. Now, what is an RS complex? If you look at this abnormal ECG, which is representing the RVH, and we scan through the leads V1, 2, 3, 4, 5, 6, you will see that we are having RS complexes. Okay, or in an easier way, you can also think that we have deep S waves. Okay, that means the QRS complex are majorly negative. Okay, so what's the reason behind this? To understand the reason behind the deep S waves in the leads V1 to V6, we need to understand the concept of cardiac rotation. Now this is something that I've already covered in the video of cardiac rotation, so you can pause this video and have a look at that video. And for those of you who have already seen that video, I'm just going to summarize the cardiac rotation so that it's easier for you to remember that we have deep S waves in leads V1 to V6 in case of RVH. So looking at this middle figure, you'll see that this is the normal rotation of the heart. In case of right ventricular hypertrophy, the right ventricle will become anterior to the left ventricle. Okay, and the transition zone will shift clockwise. Now why am I saying that it shifts clockwise? Because we will be looking at the heart from below the diaphragm, just like we see the CT or the MRI images of the transverse section of the abdomen or the chest. Okay, so when you are looking from below the diaphragm, you will see that there is a shift of the transition zone from V3, V4 to V5 and V6. Okay, so there is a clockwise shift of the transition zone from V3, V4 to V5 and V6. Normally the transition zone is found in the leads V3 and V4 in a normal heart. Similarly, coming on to the right side of this figure, you will see when we have left ventricular hypertrophy, the left ventricle becomes more anterior and there is shift of the transition zone again from V3, V4 to V1 or V2. Since if we are looking at this figure from below the diaphragm, the direction of the shift is counterclockwise, therefore it is also called counterclockwise rotation. So this is how there is shift of the transition zone in case of RVH and LVH. Okay. Now, if you look at these two types of rotations, you will see that it's representing a right ventricular hypertrophy, since the right ventricle is now occupying the interior portion of the heart. This one is the normal position of the heart. Now the right side of the heart has become more anterior. Okay. Now we know that when the right side of the heart becomes more anterior, there is a shift of the transition zone from V3 and V4 towards V5 and V6. So that is what we are seeing here. In this, the transition zone has shifted to the lead V5. In this one, the transition zone has shifted to the lead V6. Now, if you look at the morphology of the QRS complexes from the leads V1 to V6, you will notice that you are having deep S waves. Therefore, the reason of getting S waves from V1 to V6 is the clockwise rotation of the transition zone from V3, V4 to V5 and V6, leading to the change in the morphologies of the QRS complexes in a way that it has now deeper S waves in all the precordial leads. So again, if you try to look at this abnormal ECG, you will see that you have deeper S waves, okay, and small R waves. But the point is that this RS complexes from V1 to V6 is something that you can also see in case of LVH. So you need to have the criteria of right axis deviation along with RS complexes in the leads V1 to V6. Okay, so let's try to find out the axis deviation. So what's the first step in finding out the axis deviation? We have to find a limb lead which has an isoelectric QRS complex, and we can see that that's the lead 1. The next step is to find the lead which is perpendicular to the lead 1. So which is the lead that is perpendicular to the lead 1? So that's the lead AVL. Okay, so this is the lead AVL. So we know that the normal axis of the AVL is plus 30 degrees. But since the deflection is negative here, we will have to move towards the other side of the AVL lead, which will make the axis of the heart as plus 150 degrees, which is clearly a case of right axis deviation. Okay, so RS complexes from leads V1 to V6 plus a right axis deviation will constitute one of the criteria for diagnosing a patient as having RVH. Now coming on to the ventricular activation time and the intrinsicoid deflection. So in case of right ventricular hypertrophy, we have prolongation of the ventricular activation time with delayed onset of the intrinsicoid deflection in the leads V1 and V2. So just a revision, if you remember, in case of LVH, we also have increased ventricular activation time, which is represented from the onset of QRS complex to the peak of R wave. The ventricular activation time is prolonged in case of RVH and turns out to be more than 0.05 seconds in case of LVH, and in case of RVH it will be more than 0.03 seconds. Okay, so there is prolongation of the ventricular activation time. So what is ventricular activation time? Just a quick revision. It's the time for the impulse to travel from endocardium towards the epicardium and then hit the electrode. Okay, so if we will be having increased thickness of the ventricle, the time it's going to take from endocardium to epicardium will increase, which will be shown in the form of increased ventricular activation time. Okay, so since there is increase in the ventricular activation time, the onset of the intrinsicoid deflection will also increase. Okay, the downward deflection from the peak of the R wave and to the return towards the baseline constitutes intrinsicoid deflection. This represents a state of the muscles of the ventricles when all the ventricular muscles have been depolarized and there is no net current flowing in the heart. Therefore, the electrodes are not recording any current and it's falling down towards the baseline. So the onset of this entire process will also be delayed. Okay, so therefore there is going to be prolongation of the ventricular activation time with delayed onset of intrinsicoid deflection in the leads V1, V2. Another point that I want to mention here is that V1, V2 are going to be the best leads for measuring the intrinsicoid deflection and the VAT in case of right ventricle, because they are closest to the right ventricle. In case of left ventricle, the leads V5 and V6 will be best to record the changes in the ventricular activation time, because the leads V5, V6 are closest to the left ventricle. Okay. Okay, so this is actually the last slide of right ventricular hypertrophy, and it's gonna be the summary of the things that we have already done. And I think that since till now you've got to know about the different things that we have to consider in diagnosing a patient as having RVH, remembering these abnormalities now will be a lot more easier. Okay, so let's read it one by one. So first of all, the ECG findings in the RVH could be in the form of abnormalities in the QRS complexes, abnormalities in the P waves, and abnormalities in the ST segment and T waves. So starting off with the abnormalities of the QRS complexes, so right axis deviation of more than 90 degrees, it's very important because this should always be present before the diagnosis of RVH is considered. So RAD is quite important for diagnosis RVH. Next, when you see that there are tall R waves in V1, then you have R waves in V1 of more than 7 mm, and then again tall R waves in V1, V2. It's basically depicting in a nutshell that you're going to have positive deflections in case of lead V1. Okay, and just try to think, why are you going to have positive deflection in V1? Because now the vector of depolarization will be shifted towards the right, which initially used to be towards the left side. Since it was initially on the left side, we generally record negative QRS complexes in the leads V1. But in case of RVH, we will be recording positive deflections or R waves in the leads V1. Okay, so this is an important difference and a change that you can quickly see in an ECG. Okay, then next comes the delayed intrinsicoid deflection in the leads V1, V2 more than 0.03 seconds. Again, RS complexes from V1 to V6, that is clockwise rotation with the right axis deviation. Okay, then S1, S2, S3 pattern in adult patients. Okay, and then you can also have features of right bundle branch block. Coming on to the abnormalities in the P waves, you know that peaking of the P waves is something that represents right atrial abnormality, and this peaked P wave is also called P pulmonale. And the last is the abnormalities in the ST segment and T waves. So just like we are having the ventricular strain pattern in the left ventricular thickness increase, we'll be having a similar kind of ECG changes in case of right ventricular hypertrophy. So you'll be seeing ST segment depression and T wave inversion, but now this time the changes are going to be in the right sided precordial leads. Okay, in the LVH, these ST segment and T wave changes were in the leads V5 and V6, but in case of RVH, it's going to be in the lead V1. So this is all about RVH. I would definitely recommend doing the LVH and RVH video together, because the things are interlinked and there are some differences and similarities which I think will be best remembered if you try to associate and do things together.